I'm going to fund free HRT for women as part of this real push we've had for the last 4 years around women's healthcare. It's been received well.
Are you actually surprised that it's gone down well? We are talking about 51% of the population that are going to go into menopause, and you are now telling them that there's the potential there if they need it for the HRT to be provided for free. So it's a wonderful good news story for you.
I set a fairly audacious goal at the start, I guess. It was a bit cheeky, but I said, look, we have to have a revolution in women's healthcare. We've no interest in making things a little bit better. We have hundreds of years of living in a world where women simply were not afforded equality. Come on, it was so obvious. We were living in a country where people couldn't talk about menopause, where a lot of women couldn't access contraception, where women with endometriosis couldn't get diagnosed with it, and when they did, couldn't get specialist care. We've never provided women's healthcare in this country at the rate that we should have. We have a very dark history, as we all know, in terms of particularly women's reproductive health. My view was, I'm a proud feminist. We're going to do this, but we're going to catch up on decades of...
So we are going for it.
We are going for it.
Minister Donnelly, thank you so very much for joining me today in the podcast studio. It's a pleasure to have you. On this historic week, you've made several exciting announcements, and it's only Tuesday. What's going to happen by Friday? I just don't know.
I don't know. I'm spending most of the rest of the week back in Wicklow, but it has been a good few days. Yeah, we yesterday, we haven't formally announced it, but it was being widely reported that I'm going to fund free HRT for women as part of this real push we've had for the last 4 years around women's healthcare. It's gone down well. It's been received well.
Are you actually surprised that it's gone down well? We are talking about 51% of the population that are going to go into menopause, and you are now telling them that there's the potential there if they need it for the HRT to be provided for free. So it's a wonderful good news story for you, and kudos to you, because I know I've worked in healthcare for 20 odd years, and I know how difficult it can be to drive kind of change, particularly if you're thinking a little bit outside the box. So I want to congratulate you on that. You've also announced the Common Conditions Scheme, but before we get into all of that,
okay,
I do want to acknowledge the fact that the Minister for Health has to be one of the most difficult jobs in government. And you actually asked Micheál Martin for that portfolio. Why?
Why did I? I love healthcare. And before I ran in 2011, I was doing healthcare. I was doing it mainly abroad, a lot of work with the NHS. I come from a background of, public service or working with charities, or when I was working in the private sector, doing healthcare or, non-profit work. And so I have some background in healthcare. I love healthcare. And the only reason to be in politics is to make things better for people, right? That's it. And there is, for my tuppence worth, there's no better opportunity to help people and to make things better for people, particularly people who can't maybe afford to pay their way through things, right? So for people who are really reliant on our country and reliant on public services, I can't think of any better way to be of some use to people than to make things better in healthcare. And there were a lot of challenges,
Well, challenges, yes, but also you can't please all the people all the time. And it does seem to be a poison chalice of sorts, because there's a hell of a lot of negativity that comes with the job. I had former Minister for Health, Mary Harney, on the podcast about a year ago. And although we received some great feedback, there was also some very angry comments, even though she served many years ago. So it's often a thankless job, and I wonder why someone would want it. But you've obviously explained the fact that you want to improve the lives of people that probably without a good healthcare system in place, lives wouldn't be as healthy. As good. Yeah,
look, it's for me, it's pretty simple. We live in this precious country of ours. And yes, we give out. And we give out about each other and our country and whatever, politicians, sure, we do that. But actually underneath it all, we're fiercely proud of our country. And you saw it in the Olympics, right? We're so proud of them. And when we leave Ireland, I spent years living and working around the world. We're fiercely proud of our country. We don't see it enough here. And in healthcare, there is too much negativity. There's far too much negativity. But for me, one of the cornerstones of a decent society and a decent republic, which is what we're trying to do, is that people can access healthcare. I lived in the States a few different times, and it's great if you have very fancy insurance. But I also saw what happened to people who didn't have fancy insurance. And they were left to die or deteriorate. And we are different to that. And Europe is different to that. But in Ireland, we are different to that. And we looked for decades to the UK and said, the NHS is this amazing healthcare service. Well, actually, when I lived in London, I moved to Camden Town years ago. I remember the first time I got sick, I rang my GP. And I thought, this is brilliant. The GP is free. Yeah. And they said, he can see you in a month. I said, but I'm sick now.
Yeah.
I don't need to see him in a month. I need to see him now. And obviously, we still have some of those conversations here. But I think if we're going to have the country we want, warts and all, part of it has to be a great health service. It'll never be perfect. No healthcare system anywhere in the world is perfect. There'll always be challenges. And even when, it's all moving in the right direction, things will go astray that you hadn't anticipated, like COVID, right? But honestly, this sounds kind of like, sure, you would say this as a politician, wouldn't you? But I really mean this. Like, for me, it has been the greatest honor of my life to be able to be part of fixing our health service, right? And you're only one member of a team, but you can have a lot of influence as the minister. And, there were a lot of challenges. There were a lot of challenges in terms of waiting lists and trolleys. But under the bonnet, we weren't set up to succeed, right? So there was a lot of inequity around the regions. So the Midwest, Limerick, one of the reasons there have been so many problems there is because they have the lowest hospital bed per capita in the country. Now, with the 3,000 beds that I announced just before the summer, they're moving to the second highest. But we had no e-health system. We didn't really have a strategic plan for rolling out beds in a regionally balanced manner. We had one of the lowest levels of hospital consultants per capita anywhere in the OECD. And as a rich country, that should not be the case. So there were a lot of challenges, but there was an awful lot to build from. Like our healthcare professionals, be it the pharmacists, our nurses, our doctors, our therapists, they really are some of the best trained anywhere in the world. They're incredible. And, we're a wealthy, progressive nation. And I had the great fortune of really strong government support. So I got a lot of money. No, I made the case. Well, I made the case for it, but between the three parties in there and the three-party leaders and Michael McGrath, Pascal Donoghue, who were in Power and Finance, and Leo Varadkar when he was Taoiseach an Taoiseach, the Micheál Martin when he was Taoiseach an Taoiseach, the Eamon Ryan, they backed our plan. And I had a lot of support. And I think our healthcare professionals did so well during COVID that it was a proof point to say anyone who says poor healthcare is inevitable, that's just false. And we must dispel that. Our healthcare workers showed during COVID that they are capable of anything. They need the right plan. They need the right supports. They need the money. They need to step up like they did in COVID. And so for me, the last 4 years, like it is an intense job, and it comes at a cost to my wife and my kids.
That's what I was going to say. The human cost.
Yeah, there is
immense.
There is a cost. There's no question about it.
Are you still talking to your wife? That's what we all want to know.
Well, she's still talking to me. Of course. She's still talking to me. She is still talking to me. But during COVID, we were working 16, 20-hour days, 7 days a week. There were times I'd come home from the department, I'd sleep on the couch for maybe 2 hours, have a shower, change clothes, and then you're back in. it was an incredibly intense period of time, obviously. You know, we were dealing with something that we hadn't dealt with in 100 years. We had imperfect information, and we were trying to, it was literally life and death on a big scale, you know. I gave an example this morning at the launch of the pharmacy report about what pharmacists did. So this is just one example. In December 21, there was a new variant coming, and it was coming at us fast, and we could see it moving across Europe day by day, and we knew when it was going to hit us. And we had a lot of vulnerable people who hadn't had a booster. And I knew that if this wave hit us before they got the booster, thousands of people, and possibly tens of thousands of people, were going to die, and going to die in the most awful circumstances through COVID. And so I got on to the GPs and said, I need you to mobilise. I insisted that the pharmacists were brought in. The advice I got was, don't bring them in. We have mass vaccine centres. The pharmacists are busy. You know, it's Christmas time. They have to make money themselves. They have to focus on the retail end of things for the next few weeks. I said no. I insisted that, and the GPs stepped up and the pharmacists stepped up in an incredible way.
Sure, I was vaccinated on Christmas Eve. I remember during the COVID was
There
Christmas
you
Eve,
go.
so I remember it well.
And it worked.
It did work. It did work.
And so that's the big opportunity we have. Is our healthcare workers really are incredible. And on women's healthcare, going back to the HRT issue, they have implemented that so probably better than anything else that we've done other than the vaccine program. There was such an appetite. I set a fairly audacious goal at the start. I guess it was a bit cheeky, but I said, look, we have to have a revolution in women's healthcare. We've no interest in making things a little bit better. You know, we have 100 years or hundreds of years of women of living in a world where women simply were not afforded equality.
And is that why you did this? Because obviously there has been huge changes in women's healthcare, and I wanted to ask you about that. Why did you decide, look, now's the time?
Well, because I was the Minister for Health. Carpe diem, you know?
Okay.
Yeah, look, it was
You'd
self-evident.
seen this, yeah.
I mean, come on. It was so obvious. We were living in a country where people couldn't talk about menopause, where a lot of women couldn't access contraception, where women with endometriosis couldn't get diagnosed with it, and when they did, couldn't get specialist care, where women couldn't get access to IVF who wanted. Well, that's couples, but you know, women looking for access to IVF, where we were seeing a big increase in youth mental health referrals, eating disorder issues. And so I just said, listen, we have never provided women's healthcare in this country at the rate that we should have. We have a very dark history, as we all know, in terms of particularly women's reproductive health, right? It's a dark history. And so, yeah, my view was, I'm a proud feminist. My view was, we're going to do this, but we're going to catch up on decades of
so we are
care
going
we should
for
provide.
it.
We are going for it, right? And I tell you what, we put a lot of money into it. And again, thanks to Pascal and Michael McGrath and the three-party leaders, I got a lot of money for it. You know, free contraception is really expensive. Free HRT, it's really expensive.
Well, I'm telling you,
IVF.
these ladies are happy with all of this.
It costs money.
It does cost money, but actually I asked Deirdre Lundy, who I'm sure you know, she's a prominent menopause specialist working here in Dublin, and I asked a few people, I told them I was sitting down with you today, what would you ask the Minister for Health if you had to ask or comment? And she actually said that she never felt that women's health was a priority until the task force and MWHIP. So she actually said she would actually just thank you. So, you know, that is just something that is coming from a woman who has dealt with women's health all her life, and we're now seeing the light at the end of the tunnel, and it is wonderful for women out there. But I suppose the question will be is, how is this HRT going to roll out? What will be the terms and conditions? Or have you finalised any of that yet? Or
That's being worked through.
Okay.
Yeah, that's being worked through. We got an initial estimate on cost that's gone up, and actually it's gone up again. I saw a post from you saying 500,000 women. And I thought, well, okay.
500,000 potentially eligible.
Right. That would be very, very expensive. So hopefully the demand is not that. We're working it through, right?
Okay.
What I want is it available for all women. And let's see what the numbers come back, the detailed numbers in terms of the likely cost. Do we need to phase it? I don't know. I don't want to phase it. I want to just bring it in. On free contraception, we phased it.
Yeah.
Right. We went from 17 to 25 to 30 to 31 to 35. And I hope to go,
When you first brought it in for the younger age group, I remember people saying, do they not think women over 35 have sex? So, inevitably there'll be backlashes with phasing in, but then phasing in can bed it in and make sure it's done properly as well. So it's about working on it and making sure that we can try and get it to as many women as we can as quickly as we can.
It's really a matter of funding.
Yeah.
Right. We all understand prioritization. The free contraception scheme, it worked. Like, would I have loved to have, been able to fund it for everybody immediately? Yeah, sure. I'd have loved to be able to do that, but we couldn't. So let's see. My goal with HRT, I'd love to see it all done at once. I think that'd be obviously the best thing to do. And it needs to be more than just the medicines, right? So it needs to include the coils. But if we're going to have coils, then you're bringing in the GP. The GPs will ask for a fee, so those things need to be worked through. And then you have examples where there's women, say, in cancer treatment who can't take the hormone therapies, but there are non-hormonal therapies that they can take.
Yeah.
So we want to include that. It needs to be inclusive. So the details are being worked through.
Yeah.
But what I would say to Deirdre Lundy and all of the others is to thank them. The difference they have all made and it's not even 4 years, because the first year and a half really was COVID. Mm-hmm. The difference they've made in 2.5 years, it's amazing. I'll just give you one example, right? In Sligo, we've rolled out this national network of see and treat gynae clinics. And so for anyone watching the podcast or listening to the podcast, before now, a GP will refer a woman to her gynecologist. She might wait a year, 2 years. In Sligo, she had to wait 4 years to see the gynecologist. The gynecologist then says, look, I need to send you for scans. Maybe that's another 6 months. Then they've got to go back to the gynecologist. Maybe that's another 3 months, 6 months. And then the gynecologist might say, I need to refer you for a procedure. Maybe that's another 3, 4, 5 months. And it's about 4 separate trips for the woman. It could be over a 5-year period, right? So in Sligo, the time that women were waiting until very recently... So we've rolled out these see and treat gynae clinics whereby the woman goes in, sees the gynecologist in the morning, goes down the corridor for the scans, comes back to the gynecologist, and if they need a minor procedure, it's done there. So it now takes about 4 hours and it's done. All the different bits and pieces are done. We're rolling out 21 of them around the country. And the Sligo one, which I opened earlier this year, they have reduced the time from 4 years to 4 weeks. That's the kind of thing that people like Deirdre and others are doing, like what they've achieved.
Yeah, it's wonderful.
Oh, it's just incredible.
And then in terms of, because we know even with elective surgeries, usually it's gynae that's cut first, those kind of things. So that inevitably will be reduced then with all of these see and treats as they pop up around the country. Is that right?
It's way down. Yeah.
Okay.
So a woman might have been scheduled, and as you say, there's a car crash, a theatre is needed. And it was interesting, gynae was one of the ones that just were cancelled. Well, not now, because you're going into a see and treat centre and they don't need an operating theatre. It's a procedural room, down the corridor, and no one else is using it. So there's now that they don't get disrupted. And we've advanced nurse practitioners involved who are just incredible. So the women's healthcare work, if every part of the HSE worked and we could roll things out as well as they have rolled out women's healthcare, we'd be in a fantastic place.
We'd be laughing, wouldn't we? So that being said, actually, with your management consultant hat on, okay, if you could start with a clean slate today and build the health service and the Department of Health from the ground up, how would you approach it, do you think?
Well, in a roundabout way, the changes that we're making are to try and, we can't do that, obviously, are to try and build what we would build in that hypothetical world. The analogy for me is reform in healthcare is like trying to upgrade the engines on an aeroplane while the aeroplane is in the air, because you can't shut down the hospitals.
Yeah.
You can't turn off the GPs. You can't shut the pharmacies down. Everything has to keep running while you do fundamental reform, right? So I think if I can answer the question in a slightly different way, what are we trying to achieve and what are the factors of how do we make that happen? What we're trying to achieve is really simple. It's universal healthcare, right? So we want healthcare to be available to everybody, really good quality care, available to everybody when they need it. That's it, right? And for more and more people, that is the case. But for, unfortunately, still far too many, that is not yet the case. So we've a long way to go. I think we're about 4 years into a 10-year journey. That's how it feels to me. And a lot of what we've been doing over the last few years, we've been rebuilding the foundations, if you like. And a lot of the benefits of what we've been doing haven't been seen yet, right? So what do? You shift as much care as you can into the community, into people's homes, into pharmacies, into GPs, into nursing homes, into primary care centres. So we've built up a whole community health service that, to be honest, wasn't there 4 years ago. So chronic disease management teams, new primary care centres, new primary care teams, older person specialist teams. General practice has been expanded. They now do chronic disease management, free contraception. They can access scans directly for their patients, which they love. I was talking to one GP in Kerry a while ago who'd been practicing for about 30 years. And he said, for the first time, he feels like he can be the GP to his patients that he wants to be because he's got the tools available. So I think one of the things you do is you shift care out of the hospitals to the greatest extent possible. And we're in the middle of that. It's not done, but this announcement today is a major part of that. You know, the idea that pharmacists will be able to prescribe, that if you've got the rash or you've got conjunctivitis or you've got a UTI or you've got whatever it is, you don't need to wait for the doctor and you don't need to take up the doctor's time, the GP's time. So today's announcement is very much part of that. Move care out of the hospitals where you can. The second big thing you have to do, I think, is build capacity. We didn't have enough stuff. We didn't have enough nurses, doctors, therapists, GPs, hospital beds, primary care centres. So we've been pouring money into building that up, right? We've opened about 1,200 beds. There's another 500 under construction. And then a few months ago, Pascal Donoghue and I launched the plan to build, as well as that 1,700, another 3,000 beds. We're building elective hospitals. We're building the National Maternity Hospital. So we're increasing the number of hospital consultants. We're basically doubling the number of hospital consultants from a little over 3,000 to 6,000. We're now at about 4,300. So we're moving.
That's with this new contract, is it?
The new contract is part of that. It's partly about just funding more posts, but there was less and less interest in the posts. The new contract, there's a lot of interest in it. So I was in the Ioneer the other day, and one of the consultants there, she said to me, there's 2 posts they're advertising and there's like a large number of phenomenal consultants have applied, most from abroad, all trained in Ireland. You know, I was in Australia for St. Patrick's Week and I met our healthcare professionals, I think in 5 different cities. And a lot of the doctors, a lot of the consultants said, we want to come home now. They didn't all say that, but they said with the new contract, it's really good money. It's a public only contract. It comes with 20,000 a year in research and development and innovation and training, which is very, very attractive. So there's a lot of interest in the new contract. So I think step 1, shift care to the community. Part 2, increase our capacity. We just didn't have enough stuff, and do it in a balanced way. So hence the Midwest needs a much bigger investment relatively than other areas, and it's getting it, right? But then the third bit is the reform piece. And we don't talk about that because it's kind of complicated. and it's not very sexy.
I was going to say it's a bit boring as well.
It is. It is boring, but without it, we have a hope, right? So look at how our hospitals are performing. Some hospitals are knocking it out of the park. They have no patients on trolleys. They have falling waiting lists. Other hospitals, less and less, but other hospitals, Limerick being the most obvious one, where the capacity is being added. They still need more capacity, but the level of reform hasn't happened as it has in some other hospitals.
And why is that?
You have to have both. I think there's a lot of reasons. There's no simple answer to that. I think partly you have to have hospital management totally bought into the new ways of working and able to lead the clinicians and work with the clinicians to implement the new ways of working. I think in Limerick, it's partly legacy. I think they've been under so much pressure for so long because they didn't have the capacity they needed, that they didn't reform in the way that some other places and more other places did, you know.
But then how do we make sure then that if we are giving hospitals or whatever we're given capacity and there are reforms that they should be implementing, how do we ensure that they do that? Who is ultimately responsible for that happening or not happening? And where does the buck stop?
Well, the book ultimately stops with whoever's in my job, right? But
that's why I asked that.
Yeah, right. I mean, ultimately it does, right? But at an operational level, it's hospital management coupled with the consultant body, right? The reality is anyone working in a hospital will tell you that it's a combination of strong management and a consultant body that is sufficiently supported and sufficiently determined to reform that will make the changes that are needed. HICWA went into UHL a few months back and they made an interesting point. They said, look, the reforms that are needed, they are starting. They have started. We sent in a fantastic new senior manager there, Sandra Broderick, a while ago. So some of the reforms are starting, but they're not yet rolled out. So your listeners will probably be aware that we're in the middle of a reset now in the Midwest where the less urgent elective care has been cancelled for a short period of time. And that comes on the back of an expert group we asked to go in earlier this year. They wrote a report. It's pretty stark in terms of the changes that are needed. And part of it is this reset, right? So we've an opportunity now to free up bed capacity. We have more bed capacity coming online in Tipperary and in Clare. We're building more than 200 more beds on site. But right now there's an opportunity to do a reset to get the modern patient flow approaches embedded in the hospital. And the expert group has gone back in and their ask of the consultant body is to really embrace these reforms. The consultants quite rightly said to me on day one, not just the consultants, the senior hospital leadership team, when I went down there first, they said, we need a lot more capacity. And they were absolutely right. So that's happening. And my ask back was, okay, I'll do that. I'll get the money from government. We'll invest the money. But there is a quid pro quo here. You have to start running the hospital in ways that worked in Tullamore, worked in Waterford, are working in Cork, worked in various hospitals around the country. So now is the time for that, because the people of the Midwest,
they're screaming for it, aren't they?
They need to be able to access care.
Is there a resistance to change in your job when you're trying to implement these new, I suppose, they're relatively thinking outside the box changes as well? Are there collective groups or cohorts that maybe have too much power that are an impediment to change, that resist what you're trying to do? Or do you find in general people want to come to the table?
I think it's a pretty mixed bag.
Okay.
In my experience, people don't resist change. They resist loss. Women's healthcare, there was no resistance. When we pay more money, there's no resistance. When we do things that are in the interests of various people, you don't those changes are embraced. I think what people resist is potential loss. And some people will just resist things. Like there was a fair bit of resistance, for example, to the transparency that we're bringing in around productivity. We kept being told, oh, we can't share this data with you. We can't share that data with you.
What kind of data are you talking about?
Well, productivity data. So the single biggest opportunity we have now that the capacity is committed to and is happening, the single biggest requirement is that we improve productivity in our health service. We have about 600,000 people waiting for their first outpatient appointment. And we have massively increased the number of consultants. But the number of outpatient appointments has not gone up at the same rate. And in fact, if the number of outpatient appointments per consultant had stayed for the last 3 years at the level it was at in 2016, so we're not looking for something mad here. This is just, can we get back to the 2016 level? If that was done, there would be no waiting. There'd be no outpatient waiting list. And so...
And why has it reduced since 2016? Or why is it not?
Well, that's a really good question. And there's lots of different opinions as to why that is the case. Some consultants, not consultants. So some people within the health service would say, yes, you increased the number of consultants, but you didn't increase the number of rooms to see patients in.
Yeah.
Or we couldn't get access to diagnostics, so we weren't able to see the patient. Or the conditions the patient have are becoming more complex, and therefore we have to spend more time with the patients. Or the healthcare we can offer is more sophisticated, so we need to spend more time with patients, right?
Or the multidisciplinary team may not be there either, like the add-ons.
Yeah, so some of it I think is quite legitimate. But what senior doctors have said to me is, okay, sure, there is some to that. There is something to that. But they said what they have seen in cases is, let's say you have a team of 4 consultants, and each one of them runs an outpatient clinic per week. So there's 4 outpatient clinics in that discipline. And now there's 6 consultants in the same discipline. They're saying, well, there aren't 6 outpatient appointments. There's still only 4 outpatient clinics shared between 6 doctors. And therefore the number of patients being seen per doctor falls. One national clinical leader, he said to me, look, COVID was a lot to do with it, and we can see it. There's a big fall off in 2020. The problem is, it's been falling since 2016. It fell in 2020, and it hasn't gone back up a little bit, but not enough. He said, look, he and his team in their outpatient day, they would see about 50 patients. And he said, because of infection prevention and control during COVID, it fell to about 30 patients. And he said, look, to be honest with you, we just never went back up to 50. And he said, we should have. And he said, actually, having this conversation, I'm going to re-engage with my colleagues, and we need to do that. But it didn't happen. And so partly that is a failure of leadership within the hospitals, no question about it. I was in the US recently to secure care for the children with scoliosis and spina bifida. And I was talking to some of them and how they run their hospitals. And they said, well, we monitor the volume of patient activity. And if a doctor is seeing too few or too many, we bring them in and we chat to them. The problem in Ireland was there was no data available. There was no system in place to even know, well, how many patients are our doctors seeing? Is it going up? Is it going down? And some people are doing a lot of work. And unfortunately, as in any organization or large system anywhere in the world, a small number of people were really doing very little. But of course, the good people see that and say, well, hang on a second. I could be spending time with my kids. I could be spending time, doing research. And so that small number of people can tend to make everyone else feel like they're mugs for doing the right thing. So we never had the data. We've now rolled out over the last 2 years it's something called HPVP, which is High Performance Visualization Platform.
See, when I see here HPV, I think of
HPV
vaccine.
Not that.
So it's not that.
Not
but
that.
I can imagine though some doctors pushing back on that and going, listen, Stephen, with all due respect, you know, we're seeing our patients. We may need to spend more time or less time with them than, you know, Dr. X beside me here. And really, you can't be performance managing me on the amount of patients that I see, because if I'm trying to run through them so I get as many done as possible, then they may not be getting the care that they deserve. So what do you say to that?
What I say to that is we absolutely can, and we never have before. And if we don't performance manage, then we will never clear the waiting lists. That's the reality. The single biggest patient safety issue in this country is not the people in the health service. Our health service is fantastic. It doesn't get it right all the time. God, we know that. And there are some catastrophic failures. But by and large, the quality of healthcare that gets provided in this country is world class. So the biggest patient safety issue we have is not the people in the system, it's the people waiting to get into the system. And so we have to bring that down to the agreed launch of care 10 to 12 weeks. We have to. And therefore you have to performance manage, right? Now, the way you do that, let's say it's, I don't know, whatever, cardiology, whatever it is, you can look at the average number of patients being seen across cardiology, right? And then a clinical director, not somebody like me, but a clinical director can sit down with you and say, Laura, you're a cardiologist and, you know, you're seeing the average complexity of patients, but you're actually seeing half as many patients as all of your colleagues in the hospital. And that's just not acceptable. You have to get up to the same level as your colleagues. And you might say, well, then you're going to have to put on an extra outpatient. You're going to have to make that available to me on a Saturday or whatever it is. So, we have to support the consultants. But we don't have those conversations in our health service. You can be sure they're held in private care, right? And they're held in many companies, but we don't do it in our public hospitals, and we have to do it. And really, there's a very modest ask, which is to say, can we please get back to the level of patients being seen that we did in 2016? And if we have to adjust for increased complexity or things like that, that's fine. We can do that. But we have to move now to a performance management environment. And the new consultant contract, which gives a lot more money to consultants, the $20,000 a year for, training and research and innovation, really the bit that works for the patient in that is the consultants can be there in the evenings, the consultant can be there at the weekend, not all the time, but more. So one consultant said to me in Cork, well, he doesn't really do many outpatient appointments at all. And we're paying this guy about €250,000. And I said, well, you have to do it. I mean, this is your job, is to see patients. And he said, well, there's no outpatient rooms available to me. And I said, well, if I came here after 6 o'clock, would there be? And if I came here on Saturday, would there be? And the hospital manager said, well, that doesn't suit his schedule. I said, well, it doesn't suit the Irish people to be paying this guy €250,000 a year to not see patients. And so the new contract is designed to say, look, you're getting paid a lot of money. You're a doctor. You've dedicated your life to helping people. So now we're paying you more, but now you got to run your outpatient clinic on the Saturday or do it in the evening. We've got to use the resources we have better than we do. So it's a very long answer to your question of how do you rebuild a health service.
And there's the private healthcare aspect too, and some doctors can work in both public and in private. So it's about trying to maximise the public aspect while they can still enjoy their private practice.
But outside the public hospitals.
Yeah, okay.
Right, so the consultants, a lot of consultants would say to me that in their view, one of the most destructive things in public healthcare, in the hospital, in our public health service, is the ability to treat private patients in it. Because they said, look, we pay a block amount of money to treat public patients, and no matter how big the list gets, the same amount of money will get paid. And private patients, money gets paid on a patient by patient basis. And guess what? There's very few private waiting lists, but there's lots of public waiting lists. And so consultants I would talk to would say they can see, they see the resources of the hospitals in some cases just not being optimized for public patients. And so one of the big recommendations out of Sláinte Care that I fully agree with is you got to move private care out of the public hospitals. In the consultant contract negotiations, the incoming government position was that you could only do public care. But on a Saturday morning or whatever it is, you couldn't do your own clinic privately. And one of the big asks of the consultants was, we've got to be able to do private care, but off-site in private facilities. So I went back to government. We had a long discussion on that, and I got agreement that we would change. It was a pretty fundamental change in the contract. But I think it's one of the things that has made it work.
But with maternity care, it's more difficult to have that conversation, isn't it?
Yeah. Maternity care, there is no private maternity hospital. There was. Yeah. It's closed. No, I think in terms of maternity care, well, what I said to some of the obstetricians who were asking about this, I said, look, you could still set up your outpatient appointments. You could still set up outpatient clinics privately if you wanted to, off-site, not in our public maternity hospitals. But yeah, when it comes to maternity care in public maternity hospitals, then you shouldn't get a better service on something as vital as maternity care just because you're able to pay an extra 2, 3, 4, 5, 6,000 euro. But that means a very significant reduction in income for the obstetricians over time. It does. It does. I'm very conscious of that. But we are committed to public care in public hospitals. And ultimately, I think that's in the best interests, and government thinks, and there's broad political agreement that is the right thing. That is the right thing to do. But I am aware over time, the new obstetricians coming in will earn less than the obstetricians who were doing public and private. But it means that they will be available for public patients, more available for public patients. I think that's a good thing. Yeah.
So there's two ongoing challenges to fix Ireland. One is housing and the other is health. My two favourite topics. I'm only messing. I don't really like talking about housing. But the Housing Commission was set up to examine problems that we face in housing, okay? And recently it recommended treating Ireland's housing crisis as an emergency. They recommended the establishment of a new body that was independent of the Department of Housing, and this new body wouldn't be hamstrung into a planning system, and that many consider not to be fit for purpose. So should there be an equivalent health commission, do you think, where it's set up that it could bypass the normal channels as appropriate? Because we saw during COVID, you could force emergency legislation through, etc. But it seems that things have slowed down a little bit again, and it's difficult to get things over the line. So do we need an independent healthcare commission, do you think?
You have to have democratic oversight. It's a government must set policy. If government stops setting policy, well, then we're moving away from a democracy. So you have to have democratic oversight. And then what? You set up another agency that sits between the Department of Health and the HSE. Like, only government can set policy. Okay. Right? That's kind of a fundamental tenet of our country. So I'm not sure what they would do, and I certainly don't think they'd be able to do it any quicker, really. Like, if you think about the last 4 years, there's a general narrative out there that, well, things are, the healthcare is kind of inevitably not moving in the right direction. It is moving in the right direction. We've a long way to go, but look at the last 4 years. We've had one of the most successful responses to COVID anywhere in the world. In no small part thanks to our health service and our healthcare workers and our pharmacists, our GPs, everyone who got involved in the vaccine campaigns and everything else. We've added more beds in the last few years than any period in a very long time. More doctors, more nurses. We've rolled out all these women's healthcare services. The cancer strategy is going from strength to strength. We've an e-health strategy that's happening. In the middle of all of this, we've completely reorganized our health service into 6 regions. This will be the 3rd year in a row that the waiting lists fall. The trolleys are falling. There's work to be done, and we've talked about Limerick. But the number of patients on trolleys is falling. The amount of time people are waiting to get care is falling. We talked about care falling from years, sometimes to months. Here in Dublin, 2 years ago, a child who was referred to an eye specialist would wait 2 to 3 years. They're now waiting 3 weeks. So the kinds of things that people are looking to happen are happening. They're not well known.
I wanted to say that. Why is there a gap between what's actually happening and what people think are happening? Because I learned just in the last couple of days that there was a survey done and people were asked, do you think hospital waiting lists have gone up or have gone down?
Yeah.
Or the trolley crisis has gone up or gone down?
Yeah.
And people thought the opposite of what had happened.
Yeah.
They thought more negative things had happened. So
Yeah.
why is there a gap?
Yeah, 3 in every 5 people who were asked, true or false, hospital waiting lists are falling. The answer is true. They've been falling for 3 years now. 3 in every 5 people said that's false. 1 in every 5 said that's true. And 1 said, I don't know. But 3 in 5 said that. So only 1 in 5 people knew that for the last 3 years, the hospital waiting lists have been falling. And why is that happening? It's happening for lots of different reasons.
Where's your PR machine?
Well, we say it. We say it a lot, right? We
No one's
say
listening.
it. I know nobody's listening. I've been saying it till I'm blue in the face. I'm saying it to you here now again, and all of your listeners, right?
Don't worry, we won't cut this bit out, okay?
Don't cut this bit out. The public discourse, the political discourse, and the media coverage of healthcare is overwhelmingly negative, and we know why that is. Partly, it's very human. If there is a tragedy that befalls someone, a child dies, something awful happens. People want to know about that. People have a right to know about that, and we have to talk about it, and we do talk about it. Partly, it's because senior people in the media know that we are all attracted to negative news, unfortunately, right? Like, turn on the news on any given day and look at how much of it is positive versus how much of it is negative. Most of it is negative. Most of it is, and here is bad news from Ireland and around the world.
It has to be bad for our mental health, doesn't it?
I don't think it's good for our mental health. And as one newspaper editor said to me, I was kind of moaning at him about all of this. He said, Stephen, if it bleeds, it leads. He said, that's the industry. And so the good work that their healthcare professionals are doing, it most of the time, it just doesn't get a look in, right? And I can tell you it has an effect on them. Before I got into politics here, I was doing healthcare abroad. And it was the same. You would talk to healthcare workers in the UK and the NHS would just be under constant criticism. And they were doing great work, like our healthcare workers are doing great work. But nobody would talk about the positives. And for them, just on a human level, they're hearing every day, this is failing, that's failing, the other is failing. And of course, the response when I say this is, oh, no, well, that's on you, on me. Well, okay, ultimately, yes, it is. But you think our nurses and our doctors don't read newspapers? You think they don't hear the radio? You think they don't watch the news? Of course they do. They're affected. They're affected by all of this. Take Limerick, right? I bet you pretty much everyone who's listening or watching this podcast will know that there are problems in Limerick in the ED. The number of people waiting for an outpatient appointment in Limerick 3 years ago was 52,000. 1 year ago was 42,000. And today it's 32,000. And it's going down and down and down. Now think about that. In 2 years, they've brought it from 52 to 32. They're close to halving it. I bet you almost nobody listening to this podcast knows that. And it's not because we haven't
said
said it.
doesn't even know it either.
Oh, no, well, the hospital know. They know because they've achieved it, right?
And doctors that are hearing all the negative news.
But people don't know that. I'll give you one example. Right, I was speaking at a big international cancer conference recently up in Farmley, and I gave a 10-minute talk. And the progress on cancer care in this country is extraordinary in terms of survivorship. So survivorship has doubled. The number of people living for 5 years or more with cancer has doubled in the last number of years. There are mind-blowing new therapies like CAR T-cell therapy that's saving lives of people who would have had no chance. Screening is going really well. We've a very high rate internationally. And I went through the talk and I was talking about all of these good things and saying because it was people in the room had achieved all this. I want to thank the people in the room. The survivorship rates are going up, smoking rates have gone down. Like it's all moving in the right direction. And I was talking about clinical trials and I said, now Ireland is a laggard on clinical trials, but here's what we're going to do about it, right? It was half a sentence in a 10-minute speech. There were 3 newspaper articles written about the conference. And the only thing the 3 articles said was Donnelly admits Ireland fails on clinical trials. So that was the coverage of the International Cancer Conference.
Oh God.
Do you know what I mean?
No,
so
that's...
Look, it's difficult, but it would certainly help our healthcare professionals working in those hospitals every day to hear.
Listen, media, anyone that's listening, will you put
positivity,
out some good news stories about our lovely doctors and nurses and everyone else in the healthcare service, which we'll get to in a second. Can I just ask you what you think about, we do tend to have a revolving door, a new Minister for Health every 4 years or so. Do you think that that's an optimal time frame to manage something as tricky and as complex as health? Like I know that you've said you've done a lot in your tenure so far, but do you think that it should be a job that is for a longer period of time? Do you want it?
I do, yeah.
For a longer period of time?
I do. I think a bit like Secretary Generals in departments, I would say about 6 or 7 years is probably the right amount. That's what we do when there isn't an electoral cycle, when it's not politicians. We try to get people in for maybe a 5-year contract. Maybe that gets extended to a 6th year. I think if you have it definitely takes time to understand the brief. I had the advantage of being the opposition health spokesperson. I had the advantage of having had worked in healthcare previously. And even with that, I had so much to learn. It does take time, and it does take time to figure out how to fix it and how to navigate it, and who to work with. I
was going to say,
right? Who's going to help and who's going to try and
I'm not going to bother phone.
Right? Who's not going to help? It's the politest way I can say it. So moving someone on after say 3 years is too early. I would say probably around 6 years is about right. But then I think people probably, there is an argument for movement then, as you have in chief executive roles, secretary general roles. You do need new people. You do need new people coming in. But yeah, there is a lot to learn.
Okay. I want to talk to you a little bit about children's mental health services, because there are a huge amount of children that aren't being looked after in a timely manner when it comes to mental health. Just take, for example, the likes of ADHD. I actually just had a doctor who specialises in ADHD in the podcast there last week. And she was saying that in the likes of CAMS, they can only see kids, the waiting list is so long, they see kids that are in dire straits. They're sick. They're very sick. If we had early intervention with a child that has ADHD and they're put in the right programme or the right meds, we can stop the deterioration of their mental health if their mental health was going to go downhill, so that they get to their teenage years and they can be happy and live a fulfilling teenage life as such. Where do we stand when it comes to mental health services for children, and how can we improve them? Because at the minute it would seem and it's not even just the newspapers that will be reporting, it's even I'm hearing it on the ground, seeing it on the ground, that they're in the toilet.
We need further investment in the mild to moderate supports, so the community-based supports, the jigsaw supports, the counselling supports, youth-appropriate centres, drop-in centres, and that whole gambit of care. And then CAMS, the CAMS service, which is for the severe presentations, there is a plan that is now being rolled out. There wasn't a national director in place to drive the service. We have a lady now in from the West who is really good, and we've given her a lot more money. Mary Butler and I announced, for example, 10 million additional, really for youth mental health, just as an additional measure this year. So Mary Butler is the Minister of State for mental health and older people. She's increased the funding. She and I have increased the funding. The new clinical director has a very clear view as to what the problem is and how we fix it.
What is the problem?
Well, I'll give you my version of her version, if you like,
yeah.
and apologies to her if I've got this wrong, right? But my understanding is part of it is the teams are not yet fully resourced. We urgently need more pediatric psychiatry. We need to bring psychology in on a par. The psychiatrists, not all of them are in agreement with that, but there needs to be psychiatry-led. There needs to be also psychology-led, so we can increase the pool of consultant-level medics available to us. Those medics need support around the country. We have, I could have the number wrong, but I think it's 79 CAMS teams around the country. They have not historically been supported in the way they need to be supported. National guidelines weren't in place. Remember the prescribing issue down in Kerry?
Yes.
There weren't guidelines in place for that. So Mary Butler and Mary really led on this, pushed for a national audit, which was very useful, and it didn't throw up the same problems around the country as we're seeing in Kerry. So we have to fully staff up the teams. There's more of that happening now. The lead consultants need more administrative support. They need more clinical support, peer-to-peer support. They're putting that in place. There's a ways to go, but they're putting that in place. And one of the things she wants, you were talking specifically about ADHD. Mm-hmm. She wants a separate pathway for ADHD. Mm-hmm. She look, ADHD is a very clear diagnosis with a clear treatment plan that can be attached. Now you can have dual diagnosis and all sorts of things, obviously, right? But she has a very clear idea about how we fix CAMS. I think the important thing to say about CAMS is it's for 1 in 50 children who need an intervention. 49 of the 50 children who need an intervention don't need to go anywhere near CAMS. They need jigsaw. They need spun out. They need, they need community-based services. They might need their GP. They may need access to medical care, but they don't necessarily need CAMS. So we fix CAMS, we increase the capacity of community, and then something that I've been pushing very hard for and will be doing more on is on prevention. The damage that has been caused by certain types of smartphone use, certain types of social media use is profound. So we've increased, like our mental health services are seeing way more children than they saw 4 years ago, way more. But the presentations are just going up and up and up. And they're going up in a way that they're not going up in cancer care or rheumatology or ophthalmology. And one of the clear drivers is just the ubiquitous nature and the profound damage that smartphones, not the phone themselves, but the way smartphones are being used, the access to social media. So Norma Foley and I have been doing a lot of work on this. There's more to be done.
But I think that I know that this is very important. And I'm a mother of 3 sons and they, 2 of them have a phone. And before they hit their teens, I was very anti-phones, quite terrible to them. They thought I was an awful mother. But if you don't give them a phone, they can't communicate with their friends because that's the way they communicate. They get left out. You're the worst mother in the world. Parents are between a rock and the hard place. Of course, we want our children to be looked after and we want their mental health intact. But then on the other side, it's almost like it's an uphill battle with the phones.
Yeah.
In terms of the real psychiatric care for kids, that we need to see coming in? Is there a recruitment drive for child and adolescent psychiatrists and psychologists? Is that all part of that consultant contract as well? Or are they harder to come by? I just feel the resources aren't there.
There's a lot. There are a lot of resources there, and there are tens of thousands of children who are in active support with our CAMS service. So there is a very active service there. The urgent referral, which is within 3 days, I don't have the number with me, but the compliance rate is very high. But there are simply too many children waiting too long to get in.
Okay.
And it's a huge worry for them. It's a huge worry for their parents, and they can be deteriorating. And I meet the mums and dads, and they're worried sick about their kids. And so I'm not for a moment saying we're where we need to be. We're not. But there is a very clear course of action within the CAMS service. So we have continued to recruit. We launched another big fund, a €10 million fund earlier this year. We need to make sure that the referrals in are the appropriate referrals, and we need to build up the service. So yes, the psychiatric and psychological care, the consultant-led and consultant-delivered care is being strengthened. The waiting lists need to come down. They are falling, but they're falling they're not falling quickly enough. Right, there's still several thousand children who are waiting. And so Mary Butler and I are working to continue to expand those services.
Actually, you're bringing in something about smoking only for under 21s, or
that's right.
Yes.
Yeah.
Do you want to?
Yeah, we went through
vaping as well. You've a bee in your bonnet about vaping too, so you might as well. You have the floor. You have the floor, Stephen. Go on.
Well, let's start with smoking.
Yes.
That's the easy one. So we've brought the bill now through second stage in the Dáil. As soon as we're back, I want to get this through all stages, and it will increase the age that cigarettes can be sold to a person from 18 to 21. Tony Houlihan, who was my first chief medical officer, Dr. Houlihan was the first person to bring this to me as an idea. I think there's actually merit in the idea that the New Zealand started with, though they've stopped, and Rishi Sunak suggested, but we'll see if it happens, which is actually just phasing it out, just phasing smoking out in terms of going up, one year per year, so that anyone born after a certain year just wouldn't smoke, or wouldn't, you wouldn't sell cigarettes to them. We're not doing that. We're going to 21. I think we'll be the first country in the EU to do it. Already, I spoke about it at a European level. Already, other health ministers around Europe are saying, you know what, this is something we need to do. The evidence is pretty clear that if we bring it up to 21, less young people will smoke. And what's really interesting is young people were polled on this, and they supported it. As in the 18, 19, 20-year-olds. Not all of them, but the majority of them said, "You know what? This that's awful stuff.
Is that not because they're all vaping?
Just get it away from us." Well, maybe some of it is. Yeah, maybe some of it is. So that's cigarettes, and then vapes. We've already said, right, it is illegal to sell vapes to anyone under the age of 18, and we've brought in other controls as well around advertising and other things.
Because vapes look sexy, like they do. The lovely little pink boxes for the girls and lovely flavours. They're really selling it to them. I can see why they'd be attractive for kids. Yeah.
I talk to kids in secondary school, including my own kids, who would say that their friends who vape all the time, they said they're out of breath by the time they get to the top of the stairs. Like, it's really affecting them. It is still addictive. And my view is this is a deeply cynical play by the tobacco industry. And they've got the sexy flavors and colors and all of that, and disposable vapes. And sure, what's the problem? And we know it's very damaging. It's also an environmental nightmare.
Well, and we just don't have the long-term data on it, but I'm sure that it will come, that this is just not good for our kids' health or anyone who vapes.
We do have sufficient data on young people. And that's why we were able to bring in the bill that we did, or the legislation that we did around up to 18. So we do have that.
Okay.
What they're working on now is adults. Respiratory physicians in Ireland, what they're saying to me, it's anecdotal, but what they're saying to me is we guarantee you that the long-term data is going to show harm for adults as well. So we're working on a second bill, which would look at colours, flavours, point of sale. You walk into a petrol station and you're just bombarded with all of this. That just shouldn't be the case, right? Like if people genuinely want to give up smoking and access to vape helps with that on a shorter, longer term, great. Because the evidence would suggest that they're a lot less bad for you than cigarettes.
But they're still not great.
They're not. And the environmental impact of these disposable vapes is very significant as well. So we've taken steps, important steps, and we've got more being drawn up.
Can I talk to you a little bit about, we did discuss children's mental health, but also occupational health when it comes to our children as well. The likes of speech and language therapists, the long waiting lists for kids to see them, and they can't get those formative years back. If a child's waiting years to see a speech and language therapist or to get an assessment, it can negatively affect them for the rest of their life. So are there plans in place to alleviate that? Because I know we're talking about getting people out of the hospital into the community. Obviously, all of that involves all of those therapists too. So where are we? Where do we stand there?
There are two different services. There are primary care services, which are for mild to moderate conditions. They are, in my world, they're the physios, the speech and language therapists, the OTs, all of those. They do children and adults, so children up to 18 in the public service, and then anyone with a medical card as an adult. And then there's the disability services that moved from health to Minister O'Gorman, to Roderick's, to Department of Children. There's good progress being made in the primary care teams. We've hired a lot more therapists. I mean, thousands more therapists over the last few years. So there's good progress being made there, and they're doing more in terms of multidisciplinary assessments. But there's still a ways for us to go. Where the bigger challenge is in the disability services, the CDNTs, the Community Disability Network teams. And the biggest problem, in my opinion, I'm talking about somebody else's brief, so I need to be conscious of that. But the biggest problem is there was a court ruling a few years ago that said that there was a case taken, and the assessment of need list, Minister Anne Rabbitte is Minister for Disabilities. She and I were working together. I was in the Department of Health at the time, and she did a fantastic job. I allocated a bunch of money, and the assessment of need list was pretty much eradicated. And we were then moving on to the waiting list you're talking about. And I'll have my figures slightly wrong, but they had fallen from a little over 70,000 to a little over, I think, 50,000, and were rapidly reducing. And then a case was taken demanding that every assessment of need was a full 36-hour assessment. And the courts agreed. Now, I'm not criticizing the court. All the judge is doing is interpreting the law. And that was their interpretation of the law. That under the law, every child has a right to this assessment of need. But what happened as a result was catastrophic for our disability services and for the children who need to use them. Because the HSC had to pivot from doing maybe 4-hour assessments, and then if a child needed a 36-hour assessment, sending the child for that full multidisciplinary assessment, to every child having to get the 36-hour assessment, including 1 in 3 children who are referred in for assessment don't need anything. So we had a system.
Is a 36-hour assessment where someone is actually in the home with the child?
Yeah, or the child might be on site.
Okay.
It's a whole multidisciplinary thing,
Okay.
right? And it is right for some children, but it is absolutely not necessary for all children. But now all of them get it. And so what happened was all of the therapists we had, the assessment of need list had gone way down. The waiting lists were falling by tens of thousands of children. Like, we were really making progress. And overnight, every child had to have a 36-hour assessment, including children who'd had the 4-hour assessment, were in active treatment. We're told, no, you got to stop. And by the way, the therapists who we were using to treat the children, which is what the therapists want to be doing, we're now going to have to pull all of them into spending huge amounts of time doing completely unnecessary assessments for children who don't need them. And again, I want to repeat, some children do need them, but our healthcare professionals are able to ascertain who they are. And that broke our disability services. A lot of therapists said, I'm not doing this. They said, I didn't train for years to be a pediatric specialist in physio to spend my weeks doing completely unnecessary assessment. I'm going to move into primary care. And so primary care is doing much better. What is needed, in my opinion, is the law needs to be changed. So
it needs to actually just be reversed?
I believe it does.
And how will that happen? How can we do that?
Government legislates.
Okay.
So a government needs to do it. There will be a lot of opposition to it. A lot of people will say, well, you're depriving these children of their right to this full assessment. That's absolutely not the case. Any child who needs a 36-hour assessment or more would get it. So there needs to be, I believe the law needs to be changed, right? And again, I'm not blaming the judge for the ruling. The judge just interprets the law. We make the law. Mm-hmm. We need to hire far more people into the disability teams. There are hundreds and hundreds of vacant places. They've done better this year. Partly the hiring embargo that we brought in the HSC meant that there were therapists who couldn't get hired into the primary care teams, who some of them went into the disability teams, which was great to see. There's more we need to do. When I talk to the therapists working in the disability teams, they say, look, it's hard work. And a lot of therapists will choose not to do the disability work. It's tougher. The therapist will tell you it's tougher work. It's very rewarding work, but it's really hard. And I'd like to see a bit more innovation in terms of, being able to rotate through primary care and disability, more development opportunities, more supports in place. So my belief is if we can change the law, if we can hire a lot more people into those teams, support them further, hire therapists back into the special schools. They were taken out of the special schools. I think that was a mistake. And we're now putting them back into the special schools. So these are the kids with some of the most profound disabilities. We can make big inroads, and we did it. Like we got the assessment of need list down. We got the waiting list down. It was still far too high, but it fell by about 20,000. And if we had continued with that progress, arguably we'd be down to very, very few. And critically, the amount of time children are waiting would be way down. So unfortunately, that case that got taken, I don't blame the parents. The parents are doing what any of us would do, which is fighting for their child. But the ruling and that really set the service back, and it's up to us to change the law and to answer the hard questions around, well, are you depriving children of their right to an assessment? Absolutely not. And the therapists, it's not my opinion, the therapists will say, look, there are some kids need 4 hours, some kids need 36 hours. They know. That's their bread and butter.
But for the parents that are listening today that are on those waiting lists that just want their child to be assessed so their child can get to a therapist, get seen to, what's the timeline like for them then? We're talking about potentially changing the law. Like, do you see this happening in the next year or two? Can we do it? What needs to happen for it to happen?
There needs to be, the legislation needs to be drafted. It needs to go to government. It needs to go through the Oireachtas. It would be a fractious debate. Okay. I predict it needs to happen. It can be done quickly. I know Minister O'Gorman has already taken important steps in terms of working with Minister Rabbitte, to make the hiring more attractive. They're getting more people in. Some parts of the country are doing better than others, partly resource, partly ways of working and how they're managing. And the other thing we need to do is we need to support them with, decent IT systems, digital health records and these things. One of the positives that has happened is the number of primary care centres around the country has grown very significantly. They're very good facilities, but of course that's of no comfort to a parent or a child who's waiting for the service. We have to be laser focused and say, you know, our targets for the rest of the healthcare service are everyone gets into the care they need within 10 to 12 weeks. And we must, on behalf of those children, achieve the same in the disability services.
And is there work being done now, or do parents need to gather together and lobby for this to happen?
Work is being done. Yeah, there have been numerous meetings of the cabinet members who were involved in this, myself and Roderick and Anne and Micheál Martin and Simon Harris and Norma Foley and others to move this along. It is an absolute priority for government. The progress that needs to be made has not yet been made at the pace that we all want it to be made. And there are, for my money, there are clear things that we can do and are doing that will resolve this. But it is such a worry for parents who are waiting.
What is the greatest health risk in Ireland today, in your opinion?
Waiting lists.
Okay. Waiting
lists. The greatest public...
I'm surprised you didn't actually say a disease of sorts.
Cigarettes. You know, there's a great book by a guy called Mark Henry that I would encourage all of your subscribers and followers to take a look at. And he takes a positive view on Ireland over 100 years. And he's got one on healthcare. And he talks about the increase in life expectancy and all of these wonderful things that are happening. And he's got a table in the book that goes through in whatever it was, 1918 or whatever year, 100 years ago. These are the top 20 killers, you know, and it was TB and, you know, cardiovascular disease. And he goes down through it all. And he says, and here's today's list. And it's completely different. Cardiovascular disease is still there. But a lot of the things that killed us 100 years ago or 50 years ago, they're gone. Things like TB. We just don't have to deal with them anymore. Antibiotics. I didn't realize this. Antibiotics only became common. Well, you're a pharmacist. You'll know this better than I will, so correct me if I'm wrong. But in the 60s, you know, and that previous to that, if you got that infection that was just going and going and going, well... Yeah,
it is amazing how with the progress that we've made. But what do they say? That the single biggest effect on healthcare in the world is vaccinations. That's what's really saved so many millions and millions of lives.
Yeah.
But you say waiting lists. That's interesting.
Well, the biggest...
So we're going to get them down.
Yeah, well, we are getting them down.
Yeah.
The biggest patient safety risk, which is different to the question of what's the biggest public health risk. I mean, there was COVID and some of the diseases. When I talk to, you know, Dr. Mike Ryan in the WHO, so he's the now Deputy Director General, I think, but head of their emergency response. Never ask a virologist or these infectious disease people what keeps them up at night, because it'll terrify you. It'll terrify you. I sat down with him and his team in Geneva one day and I asked that question. I said, so what?
You don't want to know.
What are you worried about? And they said, well... And they started telling me about all of this really, really scary stuff that they watch pop up in Latin America or some other part of the world. So there's very scary stuff out there that we need to keep watching, which is why we've had a big investment in public health and emergency response. But notwithstanding that, I think that from a public health perspective, there's a huge amount more we can do on diet and on movement at all ages. You know, the Women's Health Plan, for example, we have a new focus now on bone health and cardiovascular health post-menopause, right? So to deal with osteoporosis, to deal with some of the cardiovascular disease that happens. So I think movement and exercise, you know, resistance training and diet, I think there's from a public health perspective.
Oh, you're speaking my
You know?
language. But even the fact that you've said bone health, it's so important because we don't see our bones, and you don't know your bones are shocking until you fall on a soft carpet and you end up with a fracture, and then
Right.
you end up in hospital and you end up with all the comorbidities that come with that. So that's brilliant that is all happening, because I was actually going to ask you, is there enough focus on preventative health in Ireland today?
No, there's not. And the previous Chief Medical Officer, Professor Breda Smith, she's just finished up, but she wrote a brilliant paper for a cabinet committee talking about the layers of like a public health response to a healthy society. It was brilliant. And I said to her, right, we're going to do a new strategy. Like Healthy Ireland is fine, but it doesn't get very much money. And it's not changing, it's not moving the dial that much. It's important and it does great work, but we need a fundamental rethink about this, because the truth is the Western medicalized healthcare approach is not sustainable financially. Like in Ireland, we're going to go from 5.5 workers per pensioner to 2 workers per pensioner. So we need to figure out how to be healthier and how to live longer, healthy lives. The data from around the world shows a massive increase in life expectancy, like massive over the last 50 years. But interestingly, what it shows is the percentage of those years lived healthy before you get your chronic disease or diseases. The percentage hasn't changed. The amount has gone up, but not the percentage.
So we're being kept alive in a semi or not so semi healthy state for longer, whereas we want to be healthier. We want to live longer, but in a healthier way.
Live
as
longer
well.
and healthier.
That's it. And our last 10 years to look like we can still tie our own shoelaces. We can go grocery shop, and we are independent in as far as we can be.
Yeah. We've got to figure out at a societal level, and this isn't just an Irish issue. This is a global issue. So we always say, oh, prevention, but actually we need to invest in it and grow it in a pretty fundamental way. So there's a new public health strategy, a very ambitious strategy being worked on in the department now. We've a new Chief Medical Officer, Mary Horgan, has just started with us yesterday. She's going to now take the lead on that. So that's prevention, diet, screening, vaccines, through life, early detection of things. I was in a cancer centre in Australia, and I was talking to this Irish oncologist who's doing this mind-blowing research on advanced cancer treatment. And I said to him, right, have you any advice for me as Minister for Health? Where should I be investing my money in terms of cancer care? And he said, in anti-smoking campaigns.
Okay.
Right? He said, look, what he does is like it's Star Trek. It's amazing. But he said it's really expensive.
And what he's saying is basic.
He's saying anti-smoking. He said, you want to have the greatest effect on cancer care in Ireland, reduce the smoking rate, right? We need a much bigger focus on prevention, but we have to be clever about it, and we have to be evidence-based. We have to be very strategic about it. So hence the strategy. It's not just about giving Healthy Ireland another 10 million. It's not just about giving, the sports clubs more money, all of which we do. It's about saying, okay, hang on, a bit like our pharmacist radical departure on prescribing. It's about saying, like, if we were to set ourselves the ambition of being one of the top 3 countries or 5 countries in the world on living long, healthy lives, free of disease, free of chronic conditions, to the greatest extent possible, then what would that look like? So yeah, prevention. And some of it is so easy. I went to a kind of an older person's aerobics, I guess, if you like, but it was a rehab class for people who'd been in hospital. They were out, but their quality of life had just degraded. And this was simple stuff. They came in maybe twice a week and they did a few weights and a bit of movement, and there were physios there, and there was a amazing doctor there. I talked to one lady, and she was probably in her late 80s, maybe mid 80s. And she said she had got to a point, she'd had a fall. I think she'd probably had a break, and she had stopped moving. And she got to a point where she was sitting in a chair in her house. And by doing nothing other than coming to this class and relearning movement and strength and resistance training, she was so happy. She's like, I'm hoovering my house. I'm cooking my meals. I'm going to the shop. She got her life back.
Yeah.
And she got her life back through something like, first of all, most importantly, her quality of life was gone. Secondly, then the state is sending in carers and physios and all of it. And then she ends up in a nursing home with, you know, all of this really expensive care, when what she needed was 2 hours of aerobics a week in a class where there were probably 40 people in it.
We all need a bit of
Right?
aerobics. I'd say you do well in an aerobics class too. But that's the whole movement and the eating idea. But we know, and it would be remiss of us not to mention the fact that obesity is a huge issue here in Ireland, and it can cause a number of chronic illnesses, and we know that we have the medications for it as well now, which is fantastic. However, we definitely need basic diet and food guidance for people from the age dot. I worked in pharmacy where you would have had 3 generations of families that they didn't know how to cook a meal. So how do we bring that aspect in? The food industry needs to come on board. You walk into your local supermarket and what's on special is the Coke, it's the sweets, it's the chocolates, it's the crisps. How do we change that here? That's a podcast in itself now.
It is. It's a whole other hour. I'll have to come back to this estate that I grew up in. When fizzy drinks are cheaper than water in a shop, and crisps are cheaper and chocolate is cheaper than fruit,
A Big Mac, a Happy Meal, cheaper than a couple of punnets of strawberries.
you've got a problem.
Yeah.
You've got a problem. The processed food industry, it's so... It's cheap. And so partly you got to make sure people have enough money to be able to buy good food, right? And partly you got to make sure people have the skills and the incentives. You know, I have yet to meet a parent. There are some bad dads out there. There's not a lot of bad mums out there, but I've yet to meet a mum, and most dads, or all dads I've met anyway, who don't want the best for their child, right? And when they get an understanding of the big differences they're going to make to their child's life through the food, it does motivate people. You know, there's no question. I don't think there's any easy answer to this. You know, we've got our food pyramids, and there was another one launched a while ago, and it's very good. It allows very little chocolate.
It's a bit different to the one that we had when we were growing up, isn't it?
It is. Yeah, it's more puritanical than the one we had. This is such a big issue. I give you my view for what it's worth is I think you have to do it. You can do national policies, but actually I think you have to do it almost on a community by community basis. There are communities I work with in Wicklow where, first of all, I am making the broad statement or assumption that there is a link between the nutritional outcomes and how much money people have, because good food is more expensive, right?
Yes, and that's really clear. There is food poverty, and people will eat what they can afford to eat as well. So we'll make that clear.
So in lower income communities, it is simply harder to access the food. Not only might they not have the money they need to access it, but as a result, the market doesn't, as in the economy means, well, they have to travel further to get the food, and they may not have a car, so they can't travel further. So there's all, and even if they could, they mightn't have been given the skills to do it. And so my view is you have to do it on a community by community basis, and you have to identify all of the issues, because there's no point, doing healthy eating lessons for people who can't afford to buy the healthy food, the raw ingredients. And there's no point making sure they have the money and making sure they have the skills unless they can physically access the food and they have time to cook for themselves and for their children. So I don't think there's any easy answer to this. I think there are some things we can do with the food industry and with the retail industry to say, you've got to stop putting the crisps and the chocolate at the eye height of a 9-year-old. It's not okay. You've got to stop that very aggressive selling of the junk food. We did the sugar tax. It worked to some extent, I think, but then there was a big shift over to the non-sugar, the non-sugar drinks, which have other things in them. So I don't have a good answer for you other than it's multifactorial, and I think you've got to saturate communities with the supports that they need. And I think it takes time. I think there are probably quicker wins in working with some of the big food retailers, because the advantage we have is the quality of the food in Ireland it's second to none. The quality of our crops, the quality of our vegetables, the quality of our beef industry, our dairy industry.
Oh God, I'm salivating now because I'm a bit hungry and
right.
I'm having
food is
a
good.
steak tonight.
Like our food is good, but it is more expensive than the processed food. So I think we have to have an honest conversation with ourselves. People have to be able to afford decent food. They've got to be able to get access to decent food, and then they've got to have the skills to make the meals. We see these television programs where some expert comes in and teaches people and it transforms their lives.
Yeah.
But we can't do that for every family.
No.
But I think you got to do it on a community by community basis.
No, absolutely. We need to talk about the new pharmacy scheme because I'm a pharmacist. I'd be killed if I didn't. But it's very interesting and it's a very exciting announcement for the pharmacy sector, the community pharmacy sector, but also for the GPs that are going to benefit from it too. And ultimately, which is what the main beneficiaries of it are, our patients and our community. So can you explain what you have done today and what it's going to look like for our future?
Yeah. We're taking a pretty radical step today. It's more radical, I think, than people realise because it's something kind of technical to do with pharmacists prescribing, and that's not terribly interesting to most people, right?
But if we break it down and tell them when they come in for the conjunctivitis, your pharmacist will likely be able to give you the antibiotic cream for your eye issue. They understand.
They do, yeah. It's a pretty radical departure, which is to say that pharmacists will be able to prescribe. And phase 1, which we hope to have in place early next year, is for common conditions. They've identified 8. Expert group report came into me. We published it today. They've identified 8, including, conjunctivitis and rashes and UTI and other things.
Cold sores,
Cold sores is one of them.
Yeah.
And the idea is for these very simple conditions, common conditions, there'll be some additional training for the pharmacists. There will be protocols put in place rather than having to go into your doctor and then go back to the pharmacist. And the pharmacist give you what they knew you needed anyway. You'll just be able to get the prescription from the pharmacist, who will then be able to sell you the medicine. We're starting with 8. I think it's going to make a big difference. Our goal is that people can, get access to easier access, quicker access, closer access to medicines. GPs are very busy. And in some areas, it takes time to see the GP. No one has ever said to me, I had to wait 3 days to see a pharmacist. You can walk in off the street, you can talk to a pharmacist. And we need to tap into their expertise in a way that we haven't fully yet. Earlier this year, we gave pharmacists the ability to extend prescriptions. So it's kind of a modest step, but an important first step. They're already doing a lot more in vaccines. Now they'll be able to prescribe, hopefully early in the new year, for 8 common conditions. That will grow. And so for the simple stuff, the non-complex stuff, people won't have to go to their GP. They won't have to pay the GP fee. Now, they may well have to pay a pharmacy fee if they're a private patient, but they won't have to wait to see a GP. It frees the GPs up to see other more complex patients, which is good. It should reduce the time people have to wait to see GPs. And then the task force has recommended something even more ambitious, which is fully independent prescribing. Now, there's a lot of training, a lot of education, a lot of legislation will be required for this. But in the first instance, it means hospital pharmacists as part of multidisciplinary teams could be able to independently prescribe to patients in the hospital, and no one is better placed. At least this is what the experts will say. No one is better placed to review all of the medicines a person might be on. A person could be on 10 different medicines, 10 different medicines, and say this is not the right mix. This one here actually interacts badly with this one over here, or for what you have, there is something better. So they're not taking the role. We
can actually reduce the polypharmacy that you're on. We can take out 2 or 3 meds, which is ideal.
Yeah. So they're not replacing the doctor. Obviously, the doctor has the medical skill set. In nursing homes, they could do these polypharmacy reviews. A lot of residents in nursing homes will be on numerous medications. And the research would suggest that when the pharmacist with the right training and the right, backup can make pretty important improvements to the combination of medicines that someone might be on, working locally with GPs. And then we potentially go further, but we have a clear plan now. Common conditions. I think then the hospital-based and the multidisciplinary-based approach, get that right, and then let's see where we go. In the UK, they have this independent prescribing. It's working well. So yeah, it's a pretty radical departure, and it should mean people, rather than having to go to their GP for some of the things they have to go for, can just pop into their local pharmacist.
No, it's ideal, because we would have all seen, the mum coming in a Friday evening with the kid with a big red eye that clearly needs a bit of chloromycetin, but you have to send them to the doctor to get the prescription for it. So now the pharmacist can intervene there, which is fantastic. It's fantastic for the patient ultimately, and for time, and for primary care too. So it's a wonderful step in the right direction.
Yeah.
I am happy with it, I have to say.
Good.
And I know lots of pharmacists around the country will say, yes, absolutely, this is brilliant. Maybe we need to reduce some of the administrative burden that we currently have, though, when it comes to paperwork and things like that.
We do.
So we need to get cracking on that, and all the stakeholders come to the table. But in terms of the scheme, I know I'm absolutely thrilled.
Good.
So I had to say that to you.
Thank you.
I only have a couple more questions, then I'll let you go, but I'm like, he's here now, I might as well get it all out. Right. If there was another pandemic tomorrow morning, what do you think that you'd do differently? And do you think we'd be ready for it?
We would be ready for it. A lot of work has been done. We did our healthcare pandemic review several years ago. We have an expert group report. One of the things that was called for was a new independent agency, an emerging threats agency. Our new chief medical officer, Professor Mary Horgan, I then asked her to lead the work on that. She has come back to me with recommendations on that. And one of the points she makes in her report, we haven't published it yet, but one of the points she makes is there's been a very big investment in public health and prevention and pandemic preparedness. So we're in a much better place now. And we would be much better prepared. We have testing and tracing systems we can roll out very quickly. We have far more intensive care. We have far more, hospital capacity available to us. We have better surveillance. We have better modelling. We have established relationships now globally, because the horizon scanning bit, the looking out for the big scary stuff bit, is now happening at a well-coordinated global level. So we're in a much better place than Ireland and, many other countries were 4 years ago. But what we would do, you can't answer that question until you know what it is and what it does, right? So it depends on the severity of it. It depends on, does it affect children? Does it affect older people? Does it affect people with underlying conditions? What does it do to people? Does it require ICU? Are there vaccines available? Is there likely to be a vaccine available? What's the mortality rate of it? So there's one Mike Ryan and his team were telling me about. It was one of the bird flus that half the people who we know globally have died. Now that doesn't mean it has a 50% mortality rate. They're just the people we know. But you can't answer the question as to what you do till you know what you're dealing with. What you can do is you can be as ready as possible, both in terms of a global surveillance network, which we're part of, being hooked into rapid development of vaccines, which we're part of with the EU, having the medical care at as healthy a level as you can and robust a level as you can in Ireland, having programs of vaccines and testing and tracing that you could roll out very quickly. We do, for example, what do you call them? They're like the war, I'll get the name wrong, but it's like war games where you do, there's a phrase, what is it? You do the scenarios.
I'm sorry, I can't help you. I don't know what you're talking about.
It's like, what are they called? Where you do, you run a scenario as, right, we've just had a pathogen arrive and this is what it does.
Oh, okay, yeah. Okay.
There's a name for that that just escapes me, right? But you do dry runs.
Okay.
You know, so what happened? You know, are the guards involved? Are the health workers involved? Are the ambulance crews involved? Where you run the desktop scenarios on, well, what if it was a biological threat? What if it was a nuclear threat? What if it was a new pathogen came in, a new pandemic came in? You run all of those. The name will come to me as soon as I walk out of here.
The dry run sounds okay.
The dry run.
I think everyone understands
that kind of thing.
That's okay.
Yeah.
Okay.
Yeah.
Fair enough. The Children's Hospital. Okay. So, it's a huge cost overruns and it's been delayed by years. Do you think that Ireland's public procurement system needs to be looked at a little bit more in detail? It's not always delivering value for money. The cost of the hospital has jumped from, 700 million to 2 billion now. Will it ever be built? What are your thoughts on that?
Well, first on the hospital, it's 90-something% finished. We're getting ready to take it over and to commission it. I've been in it a few times, and when it opens up, it will be something that everyone will be very proud of, because we will be able to deliver care in a setting that truly will be one of the best children's hospitals anywhere in the world. I've been in children's hospitals around the world. This will be as good as anything anywhere in the world. And they will deliver great care there. Now, Ireland's public procurement, yes, it's not just procurement. The biggest cost is time. Biggest cost. And what happened partly because of the Children's Hospital was complex new processes were put in place for large projects to try and avoid some of the mistakes that happened on the Children's Hospital. And maybe they did, but the other thing that they did was they meant it took much longer to build things. And the single biggest cost has been that time, right? Because, construction inflation has gone through the roof. And nobody expected Russia to invade Ukraine. And the combination of the Ukrainian-Russian war and COVID meant that supply chains all around the world were disrupted and prices shot up. So we know that, but we've got to be able to build things faster. You still have to have very careful oversight in place, because it is public money and you have to be so respectful of public money, but you got to be able to move quicker. There are changes that have been made in the lifetime of this government. The major projects process had 4 major review stages that took an awful lot of time. And I met with Michael McGrath and Pascal Donoghue in their respective roles and said, it's just taking too long. It's too complex. And to their great credit, I think it was Michael McGrath was in public expenditure at the time, but Pascal was very involved as well. They brought it down from 4 to 2. That's really important. So we can now move quicker. The maximum project size before you kick into this major projects process went up from 100 million to 200 million. That was really important to us because a lot of the bed blocks we're building are somewhere between, a lot of the big healthcare projects are somewhere between 100 million and 200 million. And so we were getting caught in this major projects process for an awful lot of projects, which we now won't have to go through.
You're proposing a project, but it's over 100 million and therefore you can't get it done. Is that?
You can get it done, but you got to go through this really detailed, lengthy process.
Okay.
Right. Minister Darragh O'Brien is pretty radically overhauling the planning process. Planning process was a bit of a problem as well. What worked well during COVID was we were able to sign derogations on planning. We were able to cite an emergency, and there were rapid building technologies that we used. And in some areas, it worked really well. St. Luke's and Kilkenny, they put up, I think it's a 96 bed block. It might be a 78 bed block, but they put up a beautiful block with a local builder, rapid build, state of the art in about 6 months. And in some other parts of the country, they built very, very quickly. We need to be able to replicate that. An example we're using is the 3,000 bed building program. We launched this really ambitious plan. Earlier this year, we went and did an expression of interest, and a lot of companies internationally and locally said, yeah, we'd be interested. And we've said we're using modular build. We've gone hospital by hospital to find sites that don't need, entire sewage works redone. They're not on, endangered areas. We're going to use rapid build, and we're building them the same.
And is rapid build as sturdy as normal build, or is it more prefabricated?
No, the lifetime of these things is it's many decades.
Okay.
It's really high quality.
Okay.
But it's modular. Modular is probably a better modular build rather than rapid build. It's not cheap. It is less expensive than some of the traditional build, but it's state of the art. You would not be able to tell that there's any difference in the building. So we're trying to do replicability, so the things look broadly the same. Obviously, you need to tweak locally. Get builders or contractors to do multiple builds, so create quite large projects, which are then attractive to international companies. Use planning derogations or apply for planning derogations where we feel they're needed. And then we've had the movements on the stage gate review going from 4 to 2, and critically, the amount going from 100 million to 200 million. So that's made a big difference. We're now beginning, we can now move quicker, certainly, than we could 4 years ago.
How do we stop with the overspend, though? Do you have any ideas on that, on how we can actually say a project's going to cost this and actually comes in roughly about that, and not given the fact that I know the whole Ukraine Russia crisis, the increase in cost of construction, etc. But is there a way of insuring ourselves against the majority of that cost?
It comes back to the conversation we had about the reporting of good news versus bad news, okay, right? So everybody can name the children's hospital and say that it was very expensive, and it costed a huge amount more than was initially forecast, and it did. And I was very critical of it when I was in opposition. Very few people will be able to list any of the major projects that have come in on time and on budget. But most of our healthcare projects have come in on time and on budget. And in fact, most of the major capital works across the country, the public works, come in on time and on budget. We never talk about them because that's not newsworthy. We only talk about the ones that are delayed and over budget. But the HSE knows how to build things on time and on budget. Doesn't mean it does it all the time, and sometimes it's nobody's fault, like construction inflation. But the HSE builds things on time and on budget all the time. The Children's Hospital is not the only project that is, delayed and over budget, but it's unusual in that sense. So a lot has been learnt, and we've done the National Maternity Hospital very differently to how we set up the Children's Hospital, for example. We're building 4 elective hospitals: North Dublin, South or West Dublin, Cork and Galway. We're doing it differently. We're approaching the project management differently, the forecasting differently. We want the hospitals to be very similar. So you're saving on design. You can buy at a bulk that you couldn't do if you have 4 completely different hospitals with different systems, different equipment inside them, different approaches. So the HSE, or the state, I guess, has a poor reputation because of the Children's Hospital. But in fact, most projects are rolled out pretty well.
Okay.
Yeah.
Our nurses, are we retaining them the way we would like to? compared to, I know we've the consultants contract now and we're trying to retain our consultants or bring them back from far away, Australia, etc. I have a brother over there too. I'd love him to come back. But I'm hearing from the ground, from my nurse friends, etc., that we're training excellent nurses here in Ireland and they're going abroad. And then we're recruiting nurses from abroad and we're training them here when we're not investing in our nurses, which are really the backbone of our health system.
The training our nurses get is some of the best anywhere. And I said to you earlier, I was down in Australia for the St. Patrick's Week thing, and I was in 5 cities, I think. And in all of those cities, I met Irish healthcare professionals. I met doctors, nurses, therapists. And I met Australian healthcare providers. And they said, oh, we love the Irish doctors and the Irish nurses.
Actually, they're a great crack.
Well, they said 3 things, right? They said they're really well trained, they're really good workers, and they're really decent people. They're easy to get on with. And they love them, right? And so they actively recruit. And they have a very compelling offer. Like I was over in Perth. I'd never been in Perth before. I did a year in Bondi when I was 20 and had a full head of hair.
Did you surf?
I fell off a surfboard just several times. I did a lot of boogie boarding at the time. But it's a wonderful, it's such a good country. And they have a great offering, which is, hey, come to Perth and we'll treat you well and we'll pay you well and you get to live in this, surfer's paradise for a year or 2 or whatever you want. So the Aussies have a really compelling offer for our doctors and nurses. And a bunch of our doctors and nurses go there. But the numbers are that 90% of nurses trained in Ireland go and work in the HSE when they graduate. 9 in every 10. Nobody knows that, right? Everyone
but
thinks
is that initial figures and then they leave after a couple of years?
Well, well, maybe, but 4 in every 5 who go are back within 5 years. So most of the nurses I speak to, and most of the doctors I speak to, not all of them, but most of them say, we're here, we love it. I'm 22 or I'm 28 or whatever it is. I'm living in Sydney. I'm living in Perth, having a great time. And I love it here. But of course, I'll be home. I'll be home in a year or I'll be home in 2 years or whatever it is. Most of them come home. I think it's a very healthy thing. We forget we're a small little island. I think it's a very healthy thing that our healthcare professionals go abroad, get international experience, bring that international experience back. So we train them really well. They're really highly sought after around the world, quite rightly. Most of them don't go abroad. 9 in 10 don't. And most of those who do go abroad come home. So they're the facts.
See, when you're throwing me figures like that now, I don't feel like I can say anything. But I know that my nurse friends say that all their colleagues are leaving the profession or they're going abroad or they're burnt out and they're...
Yeah,
they love their job. They love looking after people, but it's getting to the point where it's just too much.
And in some hospitals, that is true. And you talk to nurses who are working in ED, talk to nurses working in ICU, theatre nurses, the very intense roles. That can absolutely be the case, particularly if you're in a hospital that is struggling to have not just a full team, but the same team. Because bringing in agency nursing, it's not great for continuity and for teams. Mm-hmm. We've rolled out safe staffing. So we have one of the highest ratio of nurses per capita anywhere in Europe. We have increased the nursing workforce by 9,000 nurses in the last 4 years. In fact, the biggest problem I had in terms of recruitment last year with the HSE was they hired 2,000 more people than they were sanctioned to hire, which is why we had to bring in the embargo.
That was a bit cheeky of them, wasn't it?
Yes, it was. Yeah, it was. And it caused huge problems. We should never have had to bring that embargo in. But we've increased the nursing workforce and the medical workforce at a rate that has never happened before. So let's go back. The training is really good. The nursing degree, it's a 4-year degree. It's the envy of kind of the nursing world. In the UK, it's only a 3-year degree. That 4-year degree is really highly valued. The Americans want our nurses because they're so well trained and they work hard. They want our doctors as well, right? Our training is good. The experience can be really tough in some hospitals or in some specialties, and in others it's great. I talk to nurses who love what they do, and safe staffing has been rolled out in their ward, and they've said it's made a big difference. There's more beds have been added. The waiting lists are going down. The pressure on the patients in some places is getting less because it took them less time to get into the hospital, and they really love what they do. So it is mixed, and we need to target the areas where they're under so much pressure, particularly I think EDs, number one, but other areas as well. ICU is such a tough job for nurses. It was really tough during COVID. You know, I met 2 nurses during COVID, seasoned ICU. I don't know how much experience they had, but they were seasoned, experienced nurses. They'd worked in ICU for years. They've seen everything that ICU has to throw at you. And they said for the first time in their lives, they were traumatized by COVID, and they were really traumatized. And they said it was because of how horrifically COVID kills people, and the fact that you're surrounded by people in masks, you're not surrounded by your loved ones. They found that really tough. So there are definitely nurses within our system who are burnt out, and there are nurses who have done incredible work. But what are the asks of the profession? The asks of the profession are safe staffing, which we're doing. It's not fully done, but it is nearly done. Advanced practice. It's one of the most important innovations in nursing. We're not the leading country, but we're rapidly becoming one of the leading countries in advanced nursing.
Is that nurse prescribing? Does that fall
part
under
of
the
it?
umbrella?
Yeah, they're autonomous. So the advanced nurse practitioners are fully autonomous. They can see a patient, diagnose them, treat them, prescribe, and discharge them. And what we're finding is in every specialty that they're in, and it's more and more, and in every clinical setting, from GPs to emergency departments to outpatient clinics, and every clinical setting they're in, they are successfully seeing 50 to 70% of patients who previously were waiting to see a consultant. It's incredible.
Okay.
In Dublin, children, I think I might have said this earlier on, children who were referred for an eye specialist were waiting 3 years, 2 to 3 years. They're now waiting weeks, mainly because of nurse-led teams in the community where they're specialists, they're advanced nurse practitioners in ophthalmology, and they can do an awful lot of the work that the consultants don't need to do and never needed to do. Now think about this, right? This blew my mind. When I saw it first, I said, this couldn't be true. I was introduced to some of the advanced nurse practitioner-led teams, and they said, yeah, we're doing 70% of the patients, 50%, 80%. So that can't be right. Because if that's right, our entire model of care needs to be turned on its head, right? A lot more of it needs to be nurse-led. Imagine we could take half the patients who are waiting to see a consultant and have them treated by nurses. And by the way, when you talk to the patients, they love being treated by the nurses, right? They get on very well with the nurses. They trust them.
Actually, the nurses do be patting them on the head and everything. They're great.
They are, our advanced nurse practitioners are incredible. So the profession asked for growth. That's happening. They asked for safe staffing. That's happening. They wanted a lot of investment in advanced practice. That's happening. Further continuous professional development. That's happening. So I'm not saying it's all roses. It's not. But, you know, the IMO themselves, I think, would say, yes, we want change, and yes, there are challenges. But yes, I think the IMO would say, look, there are really good things happening in the nursing profession in Ireland. The thing where the biggest move now is doubling the number of college places, because we are totally reliant on international nursing. And every single nurse who comes here from abroad, we value and is welcomed, and thank God they have come here, because if they didn't, we couldn't run our hospitals. But it's not fair for Ireland, as one of the richest countries, to be constantly pulling in nurses from different parts of the world. It's okay if we're doing it as a partnership, like with Kenya. We're putting in place a partnership now with Kenya to invest in Kenyan nurses, Kenyan leadership, bring them over here, give them additional training. But we can't keep taking from a global market. We have to provide more of our own nurses. Less than half the nurses registering now, less than half the nursing workforce is Irish trained. That's not fair on the global, on other countries.
Does it cause an issue with a language barrier as well in the nursing teams? Have you heard any of that feedback?
No. It may. I'm sure. I'm sure there'll be cases where that is the case. Certainly, our own nurses will say that some of the international nurses coming in, there is quite a significant integration required. They don't know Ireland. They don't know our protocols. They've been trained in a different country, so there is an additional training load falls to the nurses here, to the more senior nurses here. But we ran the numbers early on in the government to say how many nurses do we need and what's our pipeline. And the short answer is we need to double college places. So when Simon Harris was in higher ed, I met up with him and I met up with Taoiseach Taoiseach at the time and said, we need a big, bold initiative now. We're funding nursing places in the north. It's a temporary thing, but it's been very valuable. We've now increased the number of nursing places by several hundred, and now we're going to keep going year by year. There's a lot of appetite from the nursing schools to do it. They need money, obviously, to do it. We have nurses training abroad because they can't get into place here. It's really competitive to get into it, to get into the nursing degree. And so that's, I think, the biggest opportunity is we need to help the teams and the hospitals and the individual teams where they really are under pressure, and they are. We need to fully roll out safe staffing. We need to become a world leader in advanced practice. We're on our way.
Is the safe staffing having the correct amount of staff on a ward at any one time? Is that what safe staffing means?
Yeah.
Okay.
Safe staffing is working out what level of nursing you need given the acuity of the patients.
Okay.
So it's moving away from saying, okay, we need 1.9 nurses per bed. And saying, well, we don't. Sometimes we need pretty low levels of nursing supervision and sometimes we need really high levels.
Okay.
And it depends on the individual patients. And so it's a dynamic approach. But of course it requires, the overall number of nurses goes up.
Yeah.
And where it has been properly implemented, it really is making a big difference.
Well, I had my 3 babies with the community midwives in Hollis Street. So it was the midwife-led team, and you just see your GP for every second visit when you're coming up to, giving birth. And I just loved it. It was just brilliant. So, and they were there for all the deliveries. I didn't need an obstetrician, but I was one of the lucky ones. Lots of women don't have that easy birth or easy pregnancy story, but I have to say it was fantastic. And even if there was more of that for ladies or more of those options, it'd be fantastic as well.
Yeah.
How are we fixed we're coming into, I know we're like August, we're coming into, I suppose, winter flu season and that. How are our hospitals teeing up? How do you see that rolling out if we're going to inevitably have a flu situation? What do you think of our emergency departments in terms of how they're looking?
We've moved from this idea of a winter plan to a national urgent and emergency care plan, because the pressures they're at their most pronounced during RSV or waves of the flu, but there's pressures all the time. The number of patients on trolleys is falling. It's much lower now in a growing number of hospitals. The 5 hospitals with the largest trolley numbers now account for about half of all trolleys. So we're narrowing in on where the supports are needed and where patients need more support and the healthcare workers need more supports. It's a multi-annual approach. We're adding more injury units. We're adding more older persons teams in the community. We're adding more chronic disease management services to keep people out of the hospital, keep them well in the first place. We're moving to the regions, to the 6 regions, so that it's integrated care between the hospital and getting them into a step-down bed, a rehab facility, a nursing home bed, a community nursing unit. In some parts of the country, that's always worked very well. In other parts of the country, it hasn't. In other parts of the country, that relationship between the hospitals and the communities hasn't always been where it needs to be. So we've moved now to the 6 regions. That's going to help. We need good uptake of the vaccine program, the flu vaccine program. The take-up used to be pretty good from our own healthcare workers. Last winter, it was very disappointing. Some hospitals did really well. Some hospitals, it was really low. We need our own healthcare workers to be
Do you think there's
to be
vaccine
vaccinated
fatigue out there?
Yeah.
Because of COVID and that?
Yeah.
I think people are like, I just don't want any more injections. I think people think like that. You know, I've like, oh, I've been stabbed too many times and I just give me a break. So
There's certainly uptake has been lower.
Yeah.
We need it to go back up.
So yeah.
You know,
do you have a program in place to
particularly for the flu?
try and
It's
highlight
done
that?
yeah, and it's done at a hospital by hospital
Okay.
level. It really has to be clinically led. It's a peer approach. You know, it's people in the hospital doing that. We have RSV vaccines coming this year.
Yes.
Any
Any plans to roll them out in pharmacy at all? Because or even extend the vaccine program to other vaccines?
I'm not sure.
Yeah, okay.
I'm not sure how that's going to be rolled out. It's starting with very young
Babies. Isn't it? Yeah.
So it'll probably be done in the maternity hospitals, but I don't have that detail on me. So higher uptake of the flu vaccine, new RSV vaccine. There's a lot more capacity has been made available. The hospitals are working better. The integration between the hospitals and the community is improving. In some cases, it's really good. And the move to the integrated to the regions helps with that. And then it has to be managed. Weekend discharge is now getting better and better. So a lot of the issues in the emergency departments happen on Monday and Tuesday because people keep coming in, but they're not getting discharged on Saturdays and Sundays. The new consultant contract, that's one of the big things, is more senior decision makers on site.
And that's already happening, is it?
Yeah.
You're seeing those?
Yeah.
Okay.
Yeah, weekend discharge rates are going up.
Fantastic.
And there have to be the community beds for them. There's no point asking the doctors to come in if the community people aren't there saying, yes, we can take Mrs. Murphy into our, or we can bring her home to a home care package. It has to be a whole systems approach. You have to have diagnostics available at the weekend in a way that it hasn't always been available. So
it's a bit of an overhaul, isn't it?
No, it is. It is. There's a pretty fundamental modernization approach going on, and you can see the results. Like I know we all focus on the areas where it's just still completely unacceptable for patients and for workers, but more and more hospitals are seeing the numbers of patients trials go down, and they're doing it at a time when the number of people coming in is going up, and the complexity of the care they need is going up. Cork University Hospital, the figures up for the first 6 months of this year, now I'll have this slightly wrong, but it was something like, they had something like let's call it a 15% increase in the number of people coming in and a 15% reduction in the number of people on trolleys. Now, it wasn't 15 and 15, but it was that kind of ballpark. And so they had something like a 30% spread between presentations and trolleys. That's incredible. I was talking to one of the ED consultants in CUH, and I said, has this ever happened before? And he said, no. He said, no, we've never achieved this level of performance improvement before. We have to make sure that it's recognized and they're supported and it is sustained. So I'm sorry, it's a long answer to the question, but there's no silver bullet to EDs.
You give long answers to every question.
Sorry.
That's all right, I'm used to it. I want to talk a little bit about the non-public minister. We touched on the fact that it's a big job. It affects all parts of your life. But are you able to go home and wind down ever, or do the emails just keep coming in? Is it always on your mind? When you go away on holidays, can you switch off? Are you always on the phone to someone? Now, I've asked you 10 questions now, so I'm assuming the answer is going to be about half an hour. But even the threats that some ministers have had to their safety in recent weeks, months, which is absolutely awful. You should be able to do your job and be assured of your own safety.
Nobody should be threatened in their job. It doesn't matter if you're a government minister or a nurse or a doctor, because they get threatened as well at work. Nobody should be threatened at work. Our guards get threatened at work. Nobody. Our bus drivers get threatened. Nobody should be threatened at work. And that should apply to me as a government minister as much as it applies to every nurse, every bus driver, every guard, every doctor we have. Nobody should be threatened to work. And obviously nobody should be threatened at their home. I've had it. The Taoiseach's had it. Many people around the cabinet table have had it more than is talked about. It is completely unacceptable. It's become more sinister. We've now bomb threats. We had, we'd several. It was reported. Minister McEntee, it was reported. The Taoiseach, it was reported. We're having people come to houses now with balaclavas on. I mean, young men turning up in balaclavas in our country, or old men, whatever. A bunch of men arriving somewhere in balaclavas on our island has a very particular connotation. It is a direct threat and intimidation, in my view, and I think action does have to be taken. So that's that part. That's where that's at. It's not good, and you're dealing with cowards behind masks. In terms of, on a lighter note, then, right? That's the heavy stuff. On a lighter note, look, it is an intense job. You kind of have to be always available because things happen, and patient safety things happen, and you've got to be able to respond to things pretty quickly. So yeah, you need to be available. It is intense. You do work long hours. For me, the hardest part about the job, and people say to me, what is the most difficult thing about being Minister for Health? It's not the job. The job is hard and it's intense. It's trying to be a good dad and a good husband and a good son and a good brother at the same time. That's really tough because they're long days. They're long days. I think I left the department at about 9:30 last night, and it's August.
You're supposed to be on holiday.
And yeah, it's August, but I got out at about 9:30 last night and landed home at about 10:30, and that's grand for anybody from time to time. But when that just becomes your norm, which it kind of does become your norm, then it's very hard to be the dad that you want to be, and you have to be, and the husband, and the son that you have to be. So that's the most difficult bit. There is a cost to it, and certainly for any of us, I'm not talking necessarily about me, but for any of us who were kind of involved during COVID, there was a cost. But then you know what? The people who bore some of the biggest cost are our nurses and obviously the patients, but from a working perspective, were our nurses and were our doctors. And sadly we lost people in the health service to COVID, and we still have some people with long COVID and who are debilitated by it. So it is, look, it is intense, but like the opportunity to help, create a great healthcare service for people in the country. I mean, it's just such a privilege. It's such an honour. It is.
And that's what drives you, isn't it?
Yeah.
Ultimately.
Oh, sure. Why else would you be in politics?
Well, I was going to say to you, how do you deal with the negativity? Do you just not read it?
You have to. Yeah. Look, there's negativity that you have to be very respectful of and very aware of. And then there's a load of the kind of the social media stuff, much of which is, automatically generated and isn't real. Did you just have to ignore? I wouldn't be able to get out of bed in the morning if I spent any time on Twitter.
Yeah.
You just couldn't.
It's not Twitter anymore now, it's X. You really have been under a rock, haven't you?
X, And it's got much worse.
Oh, well, the freedom of speech idea that Elon has, it's outrageous now. Anyone can say anything and it's just allowed, it would seem. It's quite terrible, actually. It's
gone. Yeah, no, it's gone really bad. So look, you gotta take that negativity for what it is. The negativity within the political system, you have to be really respectful of that, because that's government TDs or opposition TDs and senators coming in and saying, "Oi, there is a problem in my local hospital," or "I have a problem, this child needs help." And that discourse tends to be around things that aren't working. They don't tend to spend a lot of time saying, this is great. Hey, the waiting list in my local hospital have been eradicated. But you've got to really, that's the job, is to be very respectful of that. And then some of the negativity is, it's real people who've had a bad time in our health service, who feel they've been let down or feel they have no voice. And so you have to be really respectful of that. And, you know, you got to meet people and you got to listen to them and you got to be very humble and not defensive. You know, like when you're meeting the parents of children with scoliosis, or you're meeting parents whose children have died, or you're meeting people who've been through really rough times, and sometimes they have been failed. You have to listen to that and you have to respect it. And then you got to try and make things better. And accept that you won't get it all right, no matter how much you might want to. You'll make mistakes, but you got to get up and, you know, try and push on. But for me, as we said at the start of the chat, there really is. It's such an honor for anybody to be able to be involved in, you know, improving the healthcare service, be it me or, you know, civil servants or doctors or nurses or whoever it is. It is a great privilege. And in the role of minister, you do have a lot of influence. You can, more than I realized actually going into office. You really can affect change. And you can't do everything. You try to do everything, you fail to do everything. You've got to pick your battles. You got to pick your battles. That's something I learned the hard way, right? But it is, you know, I came into the office this morning and there was a card. There was a lady there was a paper bag on my desk and a lady had written me a beautiful card, and we had helped her son. Well, we had helped her son. Our doctors and our nurses had helped her son, right? But he got the care he needed, and he got it. He got it in a timely manner. And she said, "Look, there's not much I can offer, but what's in this bag is my thanks." And it was baked brown bread and a cake.
Oh, lovely!
Right, and so you hold on to those moments as well, you know, and they keep you going through the more difficult times.
Minister Donnelly, are you Team Harris or Team Trump?
I thought you. I had to do a double take on that.
You did look at me. You know, are you following it closely?
I very much hope that Vice President Harris wins. Yes, I do. I had the genuinely great pleasure of meeting President Biden when he was here.
Did you?
I met him and I spoke briefly to him and shook the man's hand. And I was amazing. He's an extraordinary man. And his presidency, when you take all the personalities out of it, his presidency has been very effective. He's really done very good work. I think it was the right thing for him to step back. You know, it's none of my business. It's American politics. And I think Vice President Harris is a very impressive politician.
I think she's come out of the traps and she's surprised a lot of people with.
Yeah. And I love her VP pick. I think it was brilliant. I think it was inspired.
I read something yesterday. She's backing Trump into a corner. So whatever that means anyway.
Well, the polls are shifting, aren't they?
Yeah.
Yeah, the polls are shifting. I've a bunch of friends around America who will be out campaigning for the Democrats, and some of them who'll be very involved in her campaign. And you know, you're not meant to comment. The very correct advice is don't make comments on other people's, you know, countries in terms of their politics. But yeah,
you're in a safe space here.
Right? Yeah, sure. I would love to see Vice President Harris elected. Yeah, I would.
Okay. So that is semi-concluding our podcast. I just have my two burning questions for you, which is, what advice would you give young people today?
Generally, on anything.
If you had a piece of advice to give young people today, what would it be?
I don't know. My children range from 9 to 15. What kind of age are we talking about here? whatever. Am I overthinking this?
You're overthinking it.
Okay.
You're doing a politician on
I'm
it.
sorry.
I actually sent this little brief. Did you not get it?
I didn't get this. No.
Okay.
No, I didn't. Sorry. What advice would I give young people? Get off your phones. Put your phone down. Talk to your friends in person.
Talk to your parents.
Parents.
Don't grunt at them.
Sure. What have parents ever done for us?
Yeah.
Sorry, Mum. No, I don't mean that. Obviously. Put the phone down and live. And it's a very exciting world. And have fun. And be kind. You can't be kind all the time, but try and be kind and have fun. And put the phone down. It's a wonderful, wonderful world. You live in a great country. Enjoy it.
And Minister Donnelly, what is the meaning of life?
The meaning of life? God almighty, I have no idea what the meaning of life is. Douglas Adams told us it was 42. Who knows? I don't know. I don't know what the meaning of life is. That is way, way beyond my my abilities, But what have I learnt? What little I've learnt is kind of the same advice that I was saying to the kids, Be kind. Enjoy life. Be kind to other people, and try in whatever way you can to just make it a little bit better. I guess we're all here for a limited period of time, right? So try and make the world a little bit better than how you found it. Be that through kindness or compassion or healthcare or environmentalism or setting up a soccer club in your community or mentoring kids or whatever it might be. Just spend a little bit of time trying to make our country, just that little bit better than you found it. I think that's all we can ask for,
Minister Donnelly, it has been an absolute pleasure to have you in the hot seat. Thank you so much
Not
for your
at all.
time.
Thanks for having me.